The management of bipolar disorder requires a long-term, multidisciplinary approach due to its chronic and recurring nature. Risk factors for recurrence include younger age of onset, psychotic features, rapid cycling, more and more frequent previous episodes, comorbidities such as anxiety and substance use disorder, and persistent subthreshold symptoms. Without treatment, data shows that up to 40% of patients will experience a recurrence every year, compared to only up to 25% of those on treatment. Maintenance treatment is therefore recommended to minimize recurrences in bipolar disorder. This is important because recurrences may be associated with hospitalization, behavioral risks associated to the episode, including risk of suicide, reduced gray and white matter volumes in the brain, worsening cognitive impairment, decreased interepisodic recovery, decreased functioning, and a higher rate and severity of relapse and reduced treatment response whenever treatment is given. Early intervention, therefore, with effective maintenance treatment has been found to reverse cognitive impairment and preserve brain plasticity, particularly in those who remain episode-free. As a result, with adequate maintenance treatment, overall prognosis of the illness may be improved and illness progression may be minimized. There are some key points to consider when choosing the maintenance treatment for patients living with bipolar disorder. The most important thing is that many pharmacological treatments for the management of acute manic or depressive episodes are actually also efficacious as maintenance treatment. Generally, when considering maintenance treatment options, medications that have been effective during the acute phase should be therefore continued. There is one exception to this. Long-term treatment with antidepressants is generally not recommended due to a risk of manic or hypomanic switching and instability of mood. Once maintenance treatment has been initiated, clinical monitoring is important. Always check for adherence. The specific choice of treatment for the maintenance phase should be discussed with patients and their families whenever possible, and also should consider experience of current and prior medication use and response to prior medication. If a patient has responded previously to a treatment, he is more likely to respond again, including also family history. Safety and tolerability, of course, of each potential medication should be considered. Predominant illness polarity, and particularly the polarity of the last episode, and obviously clinical features of the episode and comorbidities such as anxiety or substance use disorder. Those things may help us pick the right treatment at the right time. Pharmacological interventions would include mood stabilizers such as lithium, valproate, or lamotrigine, but also several antipsychotics with distinct formulations that have been shown to effectively prevent relapse of mood episodes. Important consideration must be given to specific populations such as women at various stages of the reproductive cycle, children and adolescents, as well as older adults. Other biological, non-pharmacological interventions could include ECT, which stands for electroconvulsive therapy, or transcranial magnetic stimulation, TMS, among others. Additionally, adjunctive psychosocial and psychological treatments may be useful for maintenance treatment to prevent relapse and improve quality of life of the individual and their family. These treatments include psychoeducation, which is the first-line treatment to improve patients' knowledge of their condition and to create personalized coping strategies to prevent relapse, as well as CBT, cognitive behavioral therapy, that helps patients to recognize and change maladaptive thoughts, beliefs, and behaviors that contribute to symptom, as well as family-focused therapy, which is another therapy that has shown evidence. Other interventions could include interpersonal and social rhythm therapy or peer support.